data that you presented at the ACAP was taken from a larger group, which included adults. Can you share with us what the adult data said? You know, because that's kind of a different population, and maybe we're looking for a few different things there. What did you find in the adult population?
Well, I did a single site study, which means I was the only site that got to do it. And I had 26 patients in the study. They were ages 18 to 55. And we did rating scales to see where their ADHD symptoms were. And they had to have at least a 24. It was interesting because in the kids study, about 60% were male. And in my adult study, 73% were female. But that's the biggest group that's coming in and looking for treatment right now. So their baseline rating scale score was about a 33. Remember, they had to have a 24 to get in. We had 5 patients discontinue during dose optimization, but only 1 did because of side effects. And when we dose optimized everybody, we did it over several weeks. The highest dose allowed was actually 50 milligrams in the adult study, 37.5 in the kids study. And at 30 minutes after dosing, we looked at effect size based on how well they were doing on math tests. And at 30 minutes after dosing, the effect size for CTX 1301 was 1.41. Well, effect size gives you a way of comparing different drugs without directly comparing them head to head. And an effect size of 0.8, 0.9 is large, 0.5 is moderate, and lower than that, a 0.2, 0.3, that's a really low effect size. Stimulants, if you can get 0.8, 0.9, that's great. Ours at 30 minutes, 35% of the medication had been released, was 1.41. So rapid onset of effect. And then at 16 hours after dosing, looking at the math tests, the effect size was still almost 1. It was 0.98. So the medication came out of the blocks quickly. It lasted through the day and even into the evening, 16 hours after they took the medication, the effect size was almost 1. Now, about 96% had an adverse event during dose optimization. What does that mean? They just had a side effect. And the most common ones were dry mouth, anxiety, insomnia, decreased appetite, headaches, irritability, the usual suspects that you see with stimulants. One of the secondary things we looked at was the change in that investigator rating scale. Remember, we started out at about a 33, 32, and the changes were 14 points for drug. We had the dose optimization, and then they had 1 week of placebo in this study when they were doing math tests. So math tests compared to placebo, where we got the effect size and the efficacy. And the difference between drug and placebo was a 13-point difference, which is just huge for medication.
Dr. Childress, you mentioned the investigator scale, and can you explain? And I assume that was used to identify patients to enroll in the trial. Can you explain what that is and how that's measured and how you figured that out?
Sure. For people that aren't familiar, and a lot of people aren't familiar with the Adult Investigator Symptom Rating Scale because it's copyrighted and you have to pay for it to license it. We use it in clinical trials. There's a thing called the ADHD rating scale, the ADHD RS, and we're on version 5 for DSM-5 now. And it's also copyrighted, but it's cheaper to get, and a lot of people use it in clinical practice. And both of these scales just go through the 18 DSM items, and they're a 4-point Likert scale, so they go 0, 1, 2, 3. And you just go down each item when you're working with patients. The prompts that you use are a little bit different with adults. With adults, you're going to be asking about driving. You're not going to be doing that with a 6-year-old. And so it's very specific to adult symptoms when you're using the AISRS.
A lot of viewers would be interested in your perspective as a prescriber. How does titration work now? And do you think that CTX 1301 will accelerate this process of successfully titrating patients to the correct dose?
Well, I'll be titrating it the same way I titrate anything else. And one of the nice things we know about stimulants from doing clinical trials is that you can change the dose of medication weekly until you get to just the right dose of medication. That's not going to change, but I think what's going to change is people are going to be able to get to the right dose of medication, and they're going to be able to do that without having to add booster doses in the morning or in the late afternoon, early evening.